Have you ever gotten a request by others to record the meeting? Question mark. And if so, how do you reply? Question mark.
We'll get started in a minute. Just a couple more. We can get the threshold number that's crossing. I can start. Hi everyone. So we don't have intro slides, so this is the CME code on the whiteboard, green board. I'm going to put it in the chat afterwards. We have no grand rounds next week. We have grand rounds for 2 more weeks after that. So 7/16 we have Dr. Blair Grubb from University of Toledo Medical Center. And on 7/23, we have Greg Miller from Northwestern University. Okay. With that, I'm gonna, introduce our speaker who actually needs no introduction in this audience. Dr. Erica Spatz is an associate professor of cardiovascular medicine at the Yale School of Medicine. She directs the cardiovascular prevention program at Yale. She's also a new deputy editor at JACC, a former associate editor at European Heart Journal, and and before that at Circulation Cardiovascular Outcomes, Cardiovascular Quality and Outcomes Research. And then, she's of course has had a massive impact on patient-centered care, both as a clinician, but also as a scientist, and bringing this patient-centered approach not only to everyday patient interactions, but on how to think about instruments and strategies to understand better how patients want to receive care and how can we implement novel interventions into the community. And her more recent work is focusing on how to scale up community level interventions, not only in our high-risk community in the Yale New Haven health system and the community outside, but also larger national studies, including a large PCORI funder study. So without further ado, I'll just pass the baton on to Dr. Spatz, who's going to present on cardiovascular disease prevention 2024, looking to the future with fresh eyes.
Thanks so much, Rohan. It's always hard to give grand rounds in front of your own crowd when everybody knows so much about what you already do. And I titled this Looking to the Future with Fresh Eyes because I came to preventive cardiology with a background in outcomes research. And as many people know, Aria, I'm looking at you, much of prevention was not based in outcomes, but really the field has just exploded over the last decade. And it's a really thrilling time. And so since we're in the first week of July, I hope that this talk will get others excited, particularly our new fellows, and draw you into the field of preventive cardiology. So these are my disclosures, mostly just grant related. So my objectives for today are to amplify the profound public health challenges that we still face in preventing cardiovascular disease, but also to recognize new diagnostic tools and novel pharmacological agents for cardiovascular disease prevention, and then really drawing to the systems change, the new technologies and systems of care that I hope will transform how we deliver care to close gaps and address health disparities. So let's just start with some of the public health challenges. For many reasons, this is still a sobering time in our society. This is a JACC report card, the first of what I hope are more to come, that highlights enormous health inequities in cardiovascular care. Really, these disparities are laid bare in this paper that shows that there were, in a period of 20 years, there were 800,000 excess cardiovascular deaths and 24 million life years lost amongst Black adults. How do we do this? We look at what's the expected death rate compared with white individuals with the same risk factors, and look at the number of deaths and years of lives lost. Now, there's many reasons for these disparities, but we should have no tolerance for this, and this is really a charge for us to do better. We also know that our obesogenic environment is killing us. It's a huge threat. By 2030, half of the US population will qualify as having obesity. That's a BMI of over 30. We know that processed foods, sedentary lifestyle, stress, and so on impact this. And this is another area where we need to become active. The third one maybe takes you by surprise, but maybe not. Climate change, right? So how many times are we seeing extreme heat on the white consult service as a factor for why people are coming in with MIs and heart failure? Our vulnerable populations are really subject to extreme weather conditions, and this is a challenge for our next generation. And finally, the global burden of disease is evolving, but not in the same pace for all countries. Many countries that are in green are up here in this corner are actually improving their cardiovascular death rates, but the ones in orange are increasing. And when you look at what are the highest contributors in the environmental level, it's particulate matter. At the metabolic level, it's hypertension, high blood pressure. And at the behavioral level, it's dietary risk. So if we can double down on those factors, I think that we would have a lot of positive change coming. Now, it's not all doom and gloom. Many of you guys are familiar with blue zones. I call these the positive deviant communities that really have the lowest rates of heart disease and the longest longevity. And what can we learn from them? Well, these places are around the globe. They're places that extend from Loma Linda, California to Okinawa, Japan. These places have high physical activity throughout their whole lifespan, low stress, rich social interactions, and local whole foods diets. So the question is this possible to achieve? When I teach about prevention in the School of Public Health, I often propose a model that you've probably known about from Geoffrey Rose, who was a British epidemiologist. He talked about sick populations and sick individuals. This is really a two-pronged approach to prevention. So at the sick population level, the causes of disease, we think of them at the societal level, many of the things I just referred to. And the idea here is that small changes in all members produce big changes in health outcomes. It often involves changes to structure, policy, the environment, social relations, as well as economics. The limitation here is that it's not targeted to the highest risk people who we are seeing, and the effects may be modest. There's also the other side of this, which is targeting sick individuals. So I recognize that the causes of the disease are at the individual level. They may relate to genetics or lifestyle factors. It involves assessment of individualized risk factors, guideline-based therapies, and personalized approaches to reduce risk. The limitation here is that if we only focus on the highest risk people, we're going to miss people who would otherwise benefit. And the individual change is hard, right? It's hard to eat healthy if your environment around you is not conducive. So we really need a two-pronged approach. Where are some highlighted places? Many may be familiar with the North Karelia project in Finland. So in the 1960s, North Karelia had the highest cholesterol, blood pressure, and rates of smoking in the world, the highest rates of heart attack in the world, and the highest mortality from coronary heart disease, especially amongst their middle-aged men. And what these curves are showing that from 1972 to 2014, they reduced that mortality by 84%. And 2/3 of the decline came from changes in risk factors, and 1/3 because of the introduction of risk-reductive medications, primarily statins. So what's the backstory? So they hired a physician, a young physician who is all of 26 years old, Peta Puska, and he consulted with Geoffrey Rose, who I just presented to you. He said, well, you got to take this two-pronged approach. So they went big. They went to the major movers and shakers in Finland. a women's group called the Martha Organization. They had women's groups throughout, and they started to train these women in new dietary ideas or recipes that were plant-based. They went to key opinion leaders. They had public health messaging everywhere. And they went to understand how is the chain leading to increased trans fats throughout the society. Well, it turns out that vets were given farmland, but they didn't know how to farm when they came back from World War II. And instead they were raising pigs and cattle, and they were just flooding the food industry with tons of sausage packed with fat, lots of salt. So they revamped all of this, established a hypertension registry, smoking bans, and saw the reductions that we have today. So it's a real success story. Are there examples more local? We do have the example of trans fats here from 2006. New York City banned trans fats. And then nearly a decade later, the FDA banned trans fats, which is a major public health change in the US. Eric Brandt, one of our former fellows now at the University of Michigan, did this study looking at the effect of trans fats bans in the New York area, highlighting differences between counties that adopted the trans fats ban versus those that didn't. And there was a 6% reduction in MI and stroke hospitalizations between those different counties within 3 years of the trans fats ban. Again, societal level, small differences, but at the population level, big change. There's a lot of interest on the global health scale around salt and salt substitutes. In this trial, this was published in New England Journal. This was in a clustered, randomized, unblinded trial in 800 villages in rural China. That's a lot, 20,000 people. They focused on people with a history of stroke and older people who had uncontrolled blood pressure. And they introduced low sodium salt, which has 25% potassium chloride in it, and showed significant reductions in blood pressure as well as recurrent stroke rates. So it is possible to make these changes. Sometimes these things feel really big and outside of our purview, but it is possible. But, you know, population health needs to meet personalized prevention. And so for the remainder, most of the talk, I'm going to be talking about the personalized, the individual approaches that are really changing over the last decade in the field of prevention. And argue to you that both are kind of going to be needed if we're going to actually close gaps in care. So what do I mean by this personalized cardiovascular risk reduction? What's unique about preventive cardiology? You know, when we started our preventive cardiovascular health program, part of the task was to differentiate what we do from what everybody is doing, which is we're all trying to prevent disease. And that is true. And I hope that we all continue to do that. Here, I'm going to tell you a little bit about what might be different about our approach in preventive cardiology. The first is that we're thinking about people through the lifespan. We're thinking about primordial prevention, primary prevention, and secondary prevention. This means for any given woman, I'm interested in her pregnancy. I'm interested if she has any PCOS. I'm interested in her menstrual cycle. I'm interested in how she ages. And I'm interested in helping people live long and healthier lives. Oftentimes, people come to us, they feel great. They may not have symptoms, which is different for lots of other areas of cardiology, but they may have a risk factor and they're asking, well, what is my risk of having heart disease or stroke? So this is a guy who's 51 and comes in with severe hypertension. And let's kind of explore how we would approach a guy like this. So his blood pressure is 167/100. He's got prediabetes, mild dyslipidemia. He's a former smoker, sedentary, mostly eats meat and potatoes, few fruits and vegetables, and his BMI is 34. So we do think about an expansive group of risk factors that may be impacting him as well. On the right-hand side, I refer to some of these amongst in women, like pregnancy complications and premature menopause. But I also want to know more about their stress, their psychological attributes, both positive and negative. If there's any inflammatory diseases like rheumatoid arthritis or HIV, chronic kidney disease, LPA and ApoB, lipoproteins, and metabolic syndrome. I'm also really interested in their social determinants of health, which is the wheel that I have down here. And I'll show you how these kind of come into play. So for many in primary care and for most of where all of us have trained, it starts with the pooled cohort equation, which rests on 4 cohort studies. This is an advancement from the Framingham study, which was only in Framingham. And when we got the pooled cohort equation in 2013, you know, it was really exciting because it was a much more diverse, this risk calculator was built on much more diverse populations, bigger populations. And we can calculate people's risk. You've probably heard that the AHA is now endorsing a newer risk calculator called Prevent. And what's interesting about this is that it's not 4 cohorts, it's 46 cohorts. So it's not just community residents who we are getting their data from. It also includes EHR data from health systems. And this calculator is built on more than 6 million people. So it's much, much more representative. They go down in age by a decade, so we can calculate people's risks starting at age 30. It's sex specific. And what it does is that it removes race. And we're increasingly recognizing and owning that we've been putting race into models that is binary, that is sometimes not even self-identified, and that is not a biological variable. It's a social variable. So we've removed race, as is happening in many of our risk calculators, and are putting in a social deprivation index to indicate a person's social risk. And this is indicated by the zip code in which they live. Also inclusive in this Prevent calculator is the outcome of heart failure. So heart failure is accelerating in incidence profoundly in the last 20 years, and it's not part of our current risk calculators, but is part of Prevent. Finally, it recognizes cardio-kidney metabolic syndrome by incorporating urine albumin creatinine ratio. And it also incorporates diabetes and GFR. So this is what's new. And when you put this man's numbers into the Prevent calculator, his risk is 5.4%. If I had put him into the pooled cohort equation, it's 8%. So there's a difference of 3%, and that kind of moves him based on what we're going to do in terms of statin, no statin, intermediate risk or low risk. If I add in microalbuminuria and zip code from a poor neighborhood, his risk goes up to 10%. And if I put in from a high income neighborhood, his risk goes to 8%. So you can see that you could play with these numbers to understand people's different risk. This gentleman is from New Hallville. It's our lowest income neighborhood in New Haven. There is a lot of crime and violence and collective trauma and grief. And understanding these aspects of his neighborhood can be helpful in understanding what his lifetime exposures might have been that are accelerating his cardiovascular risk. I highlight a book here written by a good friend of mine, Nikki Davidoff, that's called The Other Side of Prospect, because it chronicles people like him living in New Hallville. And it's very telling, and I think important for us to understand the communities that our patients come from. So he asks, what is my risk? And I can give him a risk based on a calculator, and I can look directly at his heart arteries with a CAC score. Nothing new here, right? We've used CACs for a while now. And you guys are pretty much all probably familiar with the MESA data. I highlight these 3 graphs in particular, because I think this says it all of why CAC has been used so much. Number one is that you can see that up in the upper left-hand corner, the green is 0 CAC, the yellow is 1 to 100, and the red is over 100. And you can see that in all age groups, there's a mixture of CAC. So in the over 75 group, 85% of people are going to have CAC. It's not a great tool, you know. In the younger age group, it's actually a fairly good tool. Half of people will have CAC. And if you look at risk factor burden, there's going to be people with 0 risk factors that have evidence of atherosclerotic disease, and there's going to be people with multiple risk factors who have 0 evidence of risk of disease. So this can help us to net reclassify people. Their CAC score is important because time and time again, their CAC score is related to their chances of having cardiovascular disease or death in the next 10 years. And these are the graphs that are showing you the different levels of risk based on different levels of calcium score. I will note, we were fighting for an RCT that would say, can we treat people according to their CAC and look for outcomes? We still don't have an RCT that says treating people by their CAC score improves outcomes. This is probably the best study that I can put forward to you. It's an observational study that came from the Walter Army Reed Medical Center. They looked at people, about 17,000 consecutive patients who were prescribed statins after they had a CAC score. And they did, versus people who were not prescribed statins, they did some comparison with inverse probability weighting. And basically they were able to demonstrate benefit with statins over no statins. The more benefit came, the higher the CAC score, such that the number needed to treat for a CAC score of 1 to 100 was 100 people. But if your CAC score was greater than 100, only 12 people. So treating people based on CAC scores is helpful. But is that enough? Have we reached our pinnacle of identifying people who are at risk and then modifying that risk? And the world is rapidly changing, and it's changing before guidelines are actually telling us what to do in these situations. And that's to say that there's much more that we want to understand about plaque. Plaque just doesn't settle there. First of all, it's an evolutionary process that starts with a soft plaque that then becomes a non-calcified plaque, a mixed plaque, and a calcified plaque. And we know that these earlier plaque stages are much more active and vulnerable. In fact, by the time we get to a calcified plaque, it's already a healed plaque. What I'm seeing on that CAT scan is already a stable healed plaque. Now, I can say that the more calcified plaque you have, the more likely you are to have soft plaque, and therefore you're at higher risk. But if we can identify soft plaque, then we have a better chance of, number one, intervening earlier, potentially regressing that plaque or changing it into a more stable form. So how do we image plaque? For many of the studies, they used IVUS, and many of the intervention studies have used IVUS to show that statins, ezetimibe, PCSK9 inhibitors do a fairly good job at helping to change plaque from that soft plaque to a more calcified plaque when we use IVUS. CCTA, coronary CTAs, are highly correlated with IVUS, and so we can use a non-invasive method to detect plaque. And as you're seeing, we use FFR technology, one of the AI technologies, to look at flow across obstructive vessels. And what we're seeing now are many more companies that are offering AI-augmented coronary CAT scans to more finely phenotype the type of plaque that's there, quantify it, and potentially use it to track the course of disease before any cardiovascular events have occurred. So where some of the evidence for these kinds of more nuanced approach to approaching plaque? Some comes from the Scott Hart trial. This included 1,700 all-comers from cardiology practices. The mean age was 58. They did coronary CTAs in these people. About a third had no plaque, about a third had non-obstructive plaque, and a third had obstructive plaque. Importantly, when they classified the plaque according to the different types, low attenuation plaque, defined by attenuation of less than 30 Hounsfield units, was the most associated with cardiovascular outcomes, independent of having your CAC score, independent of other risk scores. And if you had a greater than 4% burden of low attenuation plaque, there was a much higher risk. The PROMISE data, PROMISE looked at coronary CTA, anatomical test versus functional testing with stress testing to see if starting with either of these two diagnostic tests improved outcomes. In that study as well, when they looked at the coronary CTA group, those who had who had non-calcified low attenuation plaque also had greater risk of cardiovascular events. And also they determined that if we're going to use that data, it's most useful in younger people, in women, and people with non-obstructive coronary artery disease. So it leaves us with this idea that sometimes the lowest risk patients are the ones that we should be getting the coronary CTAs in so that we can detect disease at an earlier stage and have a better chance at preventing disease outcomes. So should we be using coronary CTAs for screening? This is not yet in our guidelines. And the considerations for this is that it's expensive. There's an upfront cost. There may be a cost of using AI technology. It's not cheap to partner with these companies, and insurance may not cover it. There is radiation exposure. And again, we have no outcomes data that treating according to plaque classification and progression improves outcomes. But that might be the idea. And it could be the case that if we do that, that we long-term may prevent MIs and strokes and such. But it's unknown about how often we should be testing and how we should be using that data yet. So this is something that's an open question, but I would say is increasingly part of our approach in the prevention world. And I would say that for the most part, insurance companies are covering it, especially if there's a symptom that someone's having. Just anecdotally, I will also say that I have many people who have a family history of coronary artery disease and want to know if they're doing enough. They've gotten their LDL down to goal, and yet they're still wondering if there's still vulnerable plaque there, and this is a good population to think about a coronary CTA in. So let's address some of the other aspects of this gentleman's cardiovascular risk. Again, he feels great. He's got his high blood pressure, but he also has dyslipidemia. And we talked about his other factors. So this is also new, and you may have seen that there's a presidential advisory from the AHA that has really put a lot of attention to cardio-kidney metabolic syndrome. So this is maybe what you previously knew as syndrome X or cardiometabolic disease, and or put kidney in there. And the reason is the focus on cardio-kidney metabolic disease is that obviously you know that there's a lot of drugs that are out there that are actually improving outcomes in these spaces, thinking about SGLT2 inhibitors and GLP-1s, and I'll get to those. But we have tools, but if we're not diagnosing this early, these tools are not going to have their greatest impact. It's also really important to know that cardio-kidney metabolic syndrome doesn't only lead to cardiovascular outcomes and events, it's also leading to kidney failure, which seems obvious, but also cognitive decline, MASLD, which is the new term for non-alcoholic fatty liver disease. So this is metabolic thank you. Dysregulated associated steatotic liver disease, cancer, and then of course, cardiovascular outcomes. So what's the big deal? Why am I focusing on CKM, and why am I going to spend a little bit of time on this? These data are really sobering. So we know that higher degrees of obesity is linked with progressive premature mortality. If you have grade 3 obesity, your median survival reduction is 8 to 10 years. 8 to 10 years if you have a BMI over 40. For men and women with diabetes, they have a 13 to 14 shorter year lifespan compared to men and women without diabetes. And if you have CKD stage 4, your lifespan is shortened by more than 20 years, with death from cardiovascular disease competing with end-stage renal disease and dialysis. So getting this right is hugely important for preserving health of the population. There are stages of CKM. I don't know if anybody's ever seen this graphic or ever thought about the stages of CKM. Stage 1 starts with excess dysfunctional adipose tissue. And we're going to talk a little bit about that. Stage 2 are your metabolic risk factors. Stage 3 is often where we're coming into play. That's the subclinical cardiovascular disease that we were just referring to, subclinical heart failure. And stage 4 are people with established ASCVD. So this is not just in the primary prevention world. We are really going across the spectrum. And cardiovascular disease prevention typically sits between stages 2 and 3. So what is excess dysfunctional adiposity and how is it leading to CKM? I don't have enough time to give you all of the details, but one of the things that we learned only recently is that fat is not inert. It's an active organ. And it wasn't until 1994 that when leptin was discovered that we understood that fat is actually contributing to inflammation, adipokines, oxidative stress, and acceleration of the RAS pathway. We know that visceral and ectopic adiposity are more atherogenic than subcutaneous adiposity. So we're measuring waist circumference as a key indicator of cardiovascular risk, more predictive than BMI, by the way. And we need to recognize that there are some groups that have higher visceral adiposity leading to more CKM, and particularly in the South Asian population. So our cut points for what defines overweight and what defines waist circumference that's abnormal are shifted to lower ends in the South Asian population. And there's a lot of interesting studies that are coming out. And I think this is an exciting area that we can think about applying to our patients rather than seeing them with premature CVD, but really getting to them early by using a much more stringent cut point. I'm not going to go through the treatment by classification. This is super small print, but you can see how detailed the authors are to say that those stages of CKM have treatments, but I'm just going to give you the highlights. So it's lifestyle and attention to social determinants of health, a big emphasis on GLP-1 agonists, metformin, statins, fibrates, and icosapent ethyl, ARBs and SGLT2s, and statins, PCSK9s, and the gamut. So if you look across the stages of CKD, what you will find is that we have an armamentarium of tools that we as cardiologists are probably in one of the best positions to prescribe. So it's on us to also identify these people early on. And what's not in here, but we'll also talk about today, is inflammation. So how do we do this? Part of it is reframing the health belief model. That is to say that identifying people who are young, who are at risk for cardiovascular disease is hard because when you're young, you don't think that you're at risk. So giving people information about their biology is really important for people understanding what is their risk and how important is it for them to make lifestyle changes or adopt medications for life that are going to help. So a lot of what we're doing in our disease prevention program is actually talking a lot about the biology and getting people more in touch with what's happening in their bodies. And the amazing thing is that it resonates for people because people can understand that. And they finally, somewhat feel that people are giving them an understanding for what's happening in their body and not just giving them a label. And then what we're doing is also matching it with their biography. So what's their lived experience? What's their values? Again, I need to get buy-in for therapies that are meant to be lifelong, daily, for decades of your entire life. That's a big challenge when people leave the hospital with an MI and only 50% of people take their statins. So I emphasize this importance of shared decision-making, reframing the health model, and bringing people into this understanding of biology in order for them to take more ownership and how to take control of their life. So let's talk a little bit about obesity. We know that there have been a lot of efforts around intensive lifestyle interventions. And in fact, just before, as I was walking here today, I was seeing that JAMA has a whole series of articles on lifestyle interventions for weight management. What I've learned mostly from Anya Yastrobov, who I'm going to just kind of play a little clip here from, who's an endocrinologist and has taught me so much about obesity, is that you know, a lot of what we're doing is we're not treating weight, we're treating obesity, which is in and of itself its own disease, and we're treating the biology. So I love this. This is just a short clip. The whole thing is fun to watch. This is a surprise person will appear when I'm just going to play this little video clip because I think it says a lot. Hold on.
Okay. And hormones tell our brain how much energy we're storing. These hormones in our body that basically get stimulated when we eat food. They're nutrient stimulated hormones. They tell our brain, are we hungry? Are we full? How much energy are we storing? So there's this great, amazing communication and this amazing biology.
So we should thank our body for
We should thank our body. We should thank our body.
Thank you for all that. Yes.
And here's the deal. So then people are like, well, if we have this beautiful system and our brain wants to carry a certain amount of energy or a certain amount of fuel, then why do so many people have obesity? It's our obesogenic environment. This environment that is filled with highly processed food, lack of sleep, all this stress, lack of physical activity, all these different things in our obesogenic environment contribute to this. So what does that tell us? Well, two things. One, it says we have to fix our environment. We have to, but we have to.
Yes.
But for the people who already have obesity, we need to offer them treatment if they would like it. We need to offer them choices. We need to give them treatments that target that biology.
Because the willpower is never going to do it.
Nope.
And how long have y'all known this?
It's not something that we've been hiding. We're learning more. And eat less and move more does not work. It is not about willpower. It's about biology. It's always been about biology. We just didn't know. Now.
So I love this clip because it just embodies the kinds of conversations that we have in prevention, which is to say that like we're trying to get people to understand things differently because prevention is hard. People will come in and say, I know I have to diet and lose weight and I have to exercise more. And that just doesn't message for people. And we know so much more about obesity now. We understand that the body tries to defend a fat mass, right? So our hypothalamus is a thermostat and it's telling our stomach, how much energy we need to store in order to preserve a certain defended fat mass. And we can't overcome that with diet and exercise. That's why all of these lifestyle things are not very helpful for people who want to lose weight. So these GLP-1s are addressing a lot of the biology. It's not to dismiss lifestyle. It's incredibly important, but I tell people to work out and eat healthy for their arteries and for their muscles and their bones, not to lose weight. So a lot of this, I bring this up because again, it's reframing our understanding of biology, it's removing judgment, and it's offering people options. And that's what we're in the game to do. So let's just take a overlook of nutrient stimulated hormone therapies, the GLP-1 receptor agonists. I think this is probably, taken up 50% of our time in prevention, because sometimes it's tough to get these insurance companies to cover them. But we have a number of trials. These are trials of semaglutide. In the STEP 5 trial, looking at change in weight, there was a 15% loss of body mass. The SELECT trial, I'll come to that in a second, looking at people with established ASCVD and no diabetes, looking at cardiovascular outcomes. We saw reductions in cardiovascular disease, MI, and stroke, 20% reduction. We have the STEP Heart Failure Preserve DF trial, led by Mikhail Kasaborod, who was also a former fellow here, looking at people with HFpEF and a BMI over 30, showing changes in KCCQ, weight loss, and decrease in heart failure hospitalizations. We have the FLOW trial that looked at CKD, and across the board, we're seeing really impressive reductions in the cardiovascular CKM outcomes that we care about. In the SELECT trial, as I was mentioning, there was a 20% reduction in cardiovascular risk. And if I could take you to these curves, what you could start to discern is that the curves separate pretty early on in the treatment. And as you may know, with the GLP-1s, we're gradually increasing the dose. So we don't see a ton of weight loss early on, and yet the curves separate early on. We do see that in this trial, there was modest reduction in blood pressure, in heart rate, and in cholesterol. We'll see reductions in CRP. But we are basically understanding that a lot of these things are not just mediated by weight loss. These medications likely have anti-inflammatory properties. We're still learning a ton about what they do, but are having a very profound and early effect that's independent of weight loss. I'll say a note here, I didn't put in another slide about the STEP trial for heart failure as well. They saw changes in the mechanical function of the heart with BNP levels. So BNP usually is lower in people with obesity, and BNP levels, if you just have a person lose weight, let's say through lifestyle, their BNP levels will actually go up. And in the STEP trial, for the first time, weight loss resulted in actually lower BNP levels. So we actually think it's changing a lot of the actual physiology of heart failure that's not just mediated through weight loss. There's also the dual agonists, the GLP-1s and the GIPs. This is tirzepatide. We have two trials completed, one which is underway, the SURMOUNT-1 trial, which was led by Anya Jastreboff, showing a 20 to 25% reduction in weight. More than 50% of patients lost 25% of their body mass, so huge weight reductions with tirzepatide. A recent trial coming out showing reductions in obstructive sleep apnea, and the SURMOUNT-MMO trial is ongoing for cardiovascular outcomes. This is just a slide showing that the weight decreased according to the dose of tirzepatide, and a mean weight loss of 20% with a 15 milligram dose. Decreases in waist circumference, systolic and diastolic blood pressure, fasting insulin levels, and lipid levels. And 95% of patients with pre-diabetes reverted to normal glycemia. So what's next? There's lots of other nutrient-stimulated hormones that we'll be seeing coming down the pike, targeting other hormones like amylin and glucagon. We could look out for creglinotide, which is an amylin analog. Retatrutide is a triple agonist. There's oral semaglutide that's currently a peptide, and hopefully there will be some small molecule forms which will make them easier to take and hopefully easier to make and produce and cheaper. So lots coming through and lots of excitement around the GLP-1s. Our approach in our clinic is to go slow with titration to avoid side effects. We can increase the doses every month, and sometimes that's great at the lower doses, but sometimes we'll go even slower to reduce side effects. We always support with diet and exercise. Lean mass loss occurs with the GLP-1s, but guess what? It occurs with all forms of weight loss. So pairing a GLP-1 with exercise and diet is hugely important. And then monitoring their blood pressure and diabetes medications, because actually we can stop a lot of the medication. Let's turn to lipids. We know that LDL is continuously correlated with cardiovascular risk. This is an old graphic showing the relative risk of heart disease is logarithmically related to LDL, and the lower the LDL, the same exact risk reduction you get, even at the lowest of LDL levels. What's also coming more into fashion is thinking about cumulative LDL exposure. So this is across a person's lifetime. We have EHR data that it makes it kind of ridiculous that we only think about people cross-sectionally in time and are not using their longitudinal data to inform their risk. When you look at data of cumulative LDL exposure, we note that the accumulation, the time-weighted exposure is more associated with risk even after controlling for the last LDL level. Also noted is that there are some people who, like around middle age, will suddenly have an increase in their LDL, and those people seem to be less at risk. So thinking about if a young person comes in with high LDL, and I'm thinking about, you know, all the decades that they're going to have a high LDL for without treating, because they're never going to make it high enough on our either our pooled cohort equation risk calculator or prevent calculator, I can present to them data on LDL, cumulative LDL, to think about intervening at a much earlier time than our current guidelines suggest. There's also a lot of data that treating earlier may have more benefit. This goes back to those plaque stages, that we have a better shot at preventing heart disease if we can get statins into people at earlier stages of plaque development. This is a nifty study. I don't have time to go into it. That's looking at the value of early statin use at different decades of life, and the years of life saved when we treat earlier. There is a broader spectrum of lipid lowering than just statins. This graphic was produced by some of our medical students. Timur Kayani led this paper. This was under Ray Hugh, who just graduated. He has been leading a team of people doing a huge review of non-statin lipid therapies and putting this into an app for people. I'm just going to share with you some of the highlights. We, of course, know about PCSK9 inhibitors. These promote degradation. PCSK9 promotes degradation of LDL receptors. So fewer LDL receptors that are picking up LDL, higher the LDL. We know from genetic studies that gain and loss of function of PCSK9 is associated with higher and lower cardiovascular disease. So these fully human monoclonal antibodies reduce LDL by increasing LDL receptors, and they reduce LDL by about 60%. In the trials of Odyssey and Fourier, the absolute risk reduction was about 1.6%, about a 30% relative risk reduction. Very similar to the PCSK9s is inclisiran. Inclisiran is a small interfering RNA molecule that binds to the RNA-induced silencing complex and inhibits the hepatic translation of the PCSK9 protein. So it works very similar, but a little bit upstream than the PCSK9s by resulting in upregulation of LDL receptors on the hepatocytes. It's administered subcutaneously every 6 months. There have been a number of trials that show that the LDL reduction is around 50%. We're still waiting for outcomes data from Victorian 2P on inclisiran, but this looks promising. What I can say is that for many people who qualify for PCSK9 inhibitors, but may not be able to inject themselves every 2 weeks or not want to, inclisiran offers an alternative. A nurse needs to give the injection every 6 months, and some people prefer that. You guys have heard a lot about bempedoic acid, which inhibits ATP citrate lyase, which is an enzyme that's upstream of cholesterol, upstream of HMG-CoA reductase in the cholesterol pathway. It upregulates LDL receptors as well, improving clearance of LDL and reduces LDL levels. The LDL reduction is fairly modest. It's about 14%. It does come in formulation with ezetimibe, and then you can get about a 38% reduction in LDL. And it was approved for people with FH as well as people with ASCVD as an adjunct to statins, or in people who are statin intolerant. It's delivered as a prodrug, which is present and needs an enzyme that's present in liver cells, but it's not present in muscle cells. So the drug is not broken down in the muscle cells, and we don't get the myalgias. So that's why it's often used in people who have statin intolerance due to myalgias. These are, I'm just gonna kind of fly through these. The angiopoietin like protein 3 is another area for inhibition. Angiopoietin Protein 3 is secreted by the liver, and it inhibits LPL and endothelial lipase, which are two of the enzymes that are involved in lipoprotein metabolism. Again, loss of function of this protein has been demonstrated to be associated with cardiovascular disease, which is why it is targeted. We have evinacumab, which is a fully human monoclonal antibody. And this was tested in the ELLIPSE trial, which is looking at homozygous FH. Because this is not working through the LDL receptor, homozygous FH people don't have LDL receptors. So we're targeting LDL synthesis here. LDL was reduced by 47% and was FDA approved in 2021. So another tool in our armamentarium. I'll wrap up our lipids with just saying something about LPA. I think most of us are now pretty much universally checking LPA in people. It is a guideline from in the European Society of Cardiology and the National Lipid Association, not yet in our US guidelines. But lipoprotein A is an often ignored lipoprotein that is highly associated with cardiovascular risk. It's comprised of an ApoB containing LDL particle that's covalently linked to an ApoA. And it's atherogenic, and it's prothrombotic, and it leads to heart attacks and strokes and calcific aortic valve disease. 20% of the population has an elevated LPA. In our cardiovascular disease prevention program, 40% of people had an elevated LPA. It is higher in people of African ancestry. And how do we address LPA? We currently don't have any FDA-approved medications that target LPA reduction, although the PCSK9 inhibitors do reduce LPA by 30%. And in the Fourier and Odyssey trials, those people who had elevated LPA at baseline derived greater benefit from the PCSK9 inhibitors. So they're a key tool. There's studies that are going on that are directly targeting LPA. For example, olpasiran, which is an siRNA molecule, is directed at hepatocytes. This was tested in the OCEAN study. The amount reduction of LPA is unbelievable. So in the OCEAN study, you can see that the different milligrams were associated with a 70%, 97%, and 100% reduction in LPA levels. So really obliterating LPA. And then the Horizon trial and then the AXIA ApoA trials are using antisense oligonucleotides, and they're also showing pretty remarkable reductions in LPA. So no outcomes trials, but drugs that are pretty effective in lowering LPA levels. And this is a study that just came out that Rohan Kira's group led. And this is looking at developing a strategy for who to test LPA levels in. If it's recommended that everybody get a one-time LPA level, I should back up to say that LPA is pretty much determined early in childhood, and your levels almost don't change. It's not entirely true. There's some things that can change LPA levels, but only need a one-time test to understand if you have LPA. So if we are going to roll this out to the population, how are we going to do that? Are we going to test everybody? Through using data from 4 different cohorts. Rohan's group developed a calculator that takes into account LPA and other, that takes into account variables that can give us an estimate of who is going to have an elevated LPA level and who's going to have increased cardiovascular risk. So these included people that had premature CAD, people who have a family history of premature coronary artery disease, and other risk factors. This tool is called ARISE, and it's online. I know I'm kind of running out of time, so I want to just say a note about inflammation. So atherosclerosis is not just about lipids. I love this quote from Peter Libby. He says, our understanding of atherosclerosis has evolved beyond the view that these lesions consist of a lifeless collection of lipid debris. current evidence supports a central role for inflammation in all phases of the atherosclerotic process. So, this is an active endothelium. And if we look at CRP as a clinical marker of inflammation, CRP is pretty easy to assess. And the relative risk increases the higher the CRP level. So when we're thinking about lipids, we also want to think about CRP because together they synergistically increase cardiovascular risk. Paul Ritker's group has done a lot of work targeting CRP lowering as a means of cardiovascular risk reduction, the first trial being Jupiter using statins. This was done in people with normal LDL but elevated CRP, showing that statins versus placebo reduced cardiovascular risk. And then people thought, well, you're still lowering LDL because you're giving a statin. So he went on to the CANTOS trial, just targeting inflammation, showing, again, reduced cardiovascular risk. Other drugs like bempedoic acid also reduce CRP, and SGLT2 inhibitors reduce CRP. So we have other tools in our armamentarium. But if you look at the adjunctive use of second LDL lowering agents compared with anti-inflammatory agents, actually you get more bang for your buck, more relative risk reduction with some of the, with colchicine, actually. So if we look at ezetimibe, the 3 PCSK9 inhibitors, CANTOS and colchicine. Colchicine is going to have the greatest additional risk reduction beyond statin therapy for reducing cardiovascular risk. This was demonstrated in 2 trials, Ledoco and Colcott, where there was about a 30% reduction in MACE in people with chronic coronary disease and a 23% reduction in MACE following MI. So thinking about these lesions, when we're thinking about our coronary CTAs, mixed plaque, we're not just thinking about lowering lipids, we're also thinking about inflammation. And although these trials did not use CRP as a criterion for therapy, generally speaking, we're using CRP to think about who needs additional medications to lower inflammation. So in the final moments, I just want to kind of touch upon how we're approaching this in our care system. So we have a really terrific preventive cardiovascular health program. I'm going to give a plug for it. Maria Cantido is our nurse director, and we have a dietitian, an exercise physiologist. We work very closely with our pharmacists to do remote monitoring of blood pressure and obesity medications and non-statin lipid lowering therapies. We work really closely with our OBGYN colleagues around postpartum hypertension and cardio-OB, and we have a really big community presence. And, our project number 1 is changing this, which is what our hypertension care looks like today. It's in person. People are, coming in and they're stressed for many reasons, and the blood pressure's taken terribly, and we have really bad blood pressure control. So we're trying to address hypertension, a silent killer. This is our project number 1. It's gotten a lot of attention, including by people like John Singleton, the director who died of a stroke from uncontrolled hypertension. He's one of the people whose families are bringing attention to huge disparities in hypertension control. And part of our approach is to say that, we're not bad doctors. It's just mostly the system and the way that we are set up to manage blood pressure that's not working. So how can we change this? I kind of want to go through just a few plugs. So we have some hypertension care pathways. So these are developed by groups led by Steve Posick, where we're bringing together groups of people that say, you know what, we could treat hypertension a lot better. Let's see what Kaiser's doing. Let's see what Geisinger Health System's doing. Let's use combination therapies. Let's get people onto protocols that bring their blood pressure down. We're using a lot of remote patient monitoring. I hope that I have a new role within our health system, which is to bring more remote monitoring across our system. So I'm hoping that there's going to be a lot more wearables and that we can design new models of care in this way. I also want to highlight that we're going to be partnering with Cadence, which is going to be delivering remote monitoring for hypertension, diabetes, and heart failure across our health system. So you'll be hearing more about that. But these are thinking about new ways to manage the low-hanging fruit of chronic disease management so that we can see people who have more nuanced complexities of disease within our health system. I think I'm going to end by saying that this is not a lone project. Academic or health system and community partnerships are needed. Disease doesn't happen just by genetics or biology, and individuals are not going to be able to change their own behaviors just based on what they do. We really need community partners to address the things that I started with, which are plaguing our health system, and to get to the place of, putting New Haven on the map of a Blue Zones diet. So I will give a plug for our upcoming study that's currently going on, Pressure Check, which is involving 4 health systems, 40 community-based organizations across 4 cities. And I'm going to stop there and thank many, many people on this slide, from our preventive cardiovascular health program, our Pressure Check team, some of the digital health people I've been working with in the Pop Health team. Thank you.
Thanks, Erica. That was an excellent talk. So a lot that you covered. Anybody who wants to start off with questions? Here, Rich.
Jupiter seemed to me the perfect study because it identified an actionable thing to screen for, and it never took off. So we're not actively screening for CRP and treating with statins. So what's the difference? Like, why are we now looking at LPA and CAC? Like, so are there going to be Jupiter analog studies for CAC and LPA? But why do we think those will be more sort of successful, or what's better about them than CRP?
Right. So Jupiter looked at people with an LDL less than 130 and a CRP greater than 2. It was stopped early because of efficacy. So it had some limitations, and people said, well, maybe it was by chance that you had that, right? Terminating a trial early is never a good look, right? But they were still able to demonstrate that statins were better than placebo in reducing cardiovascular risk. The thing about it is that since that time, we have continuously moved our LDL targets to lower and lower and lower. I mean, you may see this in our EHR, like above 100 is flagged as red, regardless of your cardiovascular risk. And so oftentimes we're starting with usually we're starting with what is my cardiovascular risk, and then using therapies that are targeting risk as opposed to levels. It's only once you've moved into, I have cardiovascular disease, that we're then targeting the numbers and getting them down. So the problem with Jupiter is that our starting point is not just LDL and CRP. Our starting point needs to be a more comprehensive approach of what is my cardiovascular risk, because what might be, appropriate for one person may not be appropriate for another person at a higher level of risk.
Well, really, congratulations. I knew when we talked about starting a preventive health cardiology program in subsection that you were the right person to kind of take it to the next level. So very proud and encouraged by what you did. So thank you from all of us. My question is related to lipoprotein(a). The lipoprotein that I've tried to avoid thinking about, because it's always changing our plans and we're growing our mouths, but I guess I'm curious, can we expect lipoprotein(a) to be reduced by standard treatments for statins per se? And can you give me an estimate of how many individuals out there will have a high LDL that will normalize with standard treatments, but will still have untreated lipoprotein(a)?
Yeah. So lipoprotein(a), when you look at the cut point of, let's say it's you're using nanomoles per liter 75, nearly 20% of our population are going to have an elevated LPA. And are we going to be treating all those people? Probably not. The thing about universal screening that puts us into a really tough position is that we don't have a good answer for how to treat it. So statins will increase LPA levels. Now, that's never been observed to have an increased association with cardiovascular risk, but put a person on statin, their LPA levels will actually increase. And yet the primary approach to dealing with an elevated lipoprotein A is to put a person on statins and address all of the modifiable risk factors that that person has. So if a person comes in and LPA is high, I put them on statins, driving the LDL less than 100, and never again checking that LPA level, because I don't even want that person to know that their LPA level is going up, because I still have to convince them that that's okay. That's not going to happen. In our prevention program, because we are seeing so many people who have family history of premature coronary artery disease, that's the driver that's bringing most of the people into our clinic. We are seeing 40% of people have elevated LPA levels. And some of the people that I've been treating, like one patient had an MI at the age of 38. And a few years later, he comes to see us and we check his LPA, it's over 600. Nobody had ever checked it. And so here we are, treating this person with all of our risk reductive therapies, but never knowing that he has this, LPA level in the midst that's probably going to result in future cardiovascular events. So, but I can't treat it. PCSK9 inhibitors do reduce LPA by 30%. And they did derive more benefit in the Fourier and Odyssey trials. So that is what I primarily use. And then we are not a participant, but the OCEAN trial is going on. So thinking about olpasiran, the small interfering RNA molecule for LPA lowering. But if everybody gets tested, we're not going to know what to do with all that, with all those people that are going to be at mildly elevated and not have cardiovascular risk.
First of all, congratulations. Your program has really been but that you practice what you preach. I've seen you care for patients in different kind of context and care for extremely well. So congratulations. Would be a cardiology program. I didn't ask you a question about information, so here we go. You talked a lot about CRP and reducing CRP and targeting CRP, and we know that actually CRP is a risk marker. It's not actually a risk factor, it's a risk marker. There's very little evidence that CRP causes disease. There's one funny animal model where human CRP was expressed as map. But there's very little evidence. So I'm wondering if you've seen anything, and there are 500 different inflammatory pathways and 100. So if you've seen people paying attention to, the personalized medicine context of looking at individual inflammatory pathways or cytokines or something that we can target more specifically rather than any statin but maybe not all cytokines.
Yeah, it's a great question. And I will tell you, I've had the same concern about anchoring on CRP levels as, who has inflammation, who doesn't have inflammation, and figuring out who I should use colchicine in. Actually, in those trials, they didn't use CRP as a point of entry. So I've posed the question to people like Peter Libby and Steven Neeson, and, maybe they all kind of think the same, but they themselves use CRP as a risk stratifier for inflammation, recognizing that there's tons of other inflammatory markers that are driving disease, as well as that we could, modify that are outside of CRP. But clinically, I don't have another way to discern. So I use CRP when I'm need an excuse to start an anti-inflammatory, or sometimes I'll just start it because they meet the indication anyway. Yeah.
Probably very glad I have sick liver and a lot of front-end cytokines go up and sort of set fashion. So, I think it's very reasonable, but I think there is something that applies looking for selective hits to cytokines or pathways that may be targetable. Just wondering if you've seen anything.
Yeah, not clinically, I haven't.
Reduction in CRP based on the in the room, data is remarkable.
Mhm.
It's rapid. So I think we're going to be.
Using it a lot.
Using a lot of that.
Yeah, the GLP-1s are really amazing. I mean, I wanted to spend some time on things that are new and exciting and people are using a lot, but maybe, seeing where they've been introduced and how we're introducing them, because, the number of people who qualify for a GLP-1 is unbelievable. And in our field, we're just seeing, hit after hit of randomized controls trials, all published in the New England Journal of Medicine, impacting heart attack, strokes, heart failure, kidney disease, sleep apnea. And yeah, and it's more than just weight loss. All right.
Thanks for covering that.
Try to, all right.
Erica, that's phenomenal.
Hi.
Amazing, amazing, good.
Nice to see you. Thanks for coming.
So awesome. Of
I
course.
just wanted to.
Yeah, very impressive.
Thank you.
Just want to say.
Hey, good,
I
thank
know
you
so
for
much.
coming. Great job. I love doing here.
I saw you for giving a talk.
Oh, that's so nice.
See, it is so good. Thanks so much.
I've learned so much at play and stand, and I'm like, I knew you were badass.
It's all right.
We celebrate. So.